morning all. Let's start a new topic which is from central nervous system. So it's about anti-epileptic drugs, which means the drugs which are useful in the management of epilepsy or seizure disorders. This topic will be dealt in different sessions, and this is going to be the first part of this anti-epileptic drugs. So few points about this seizure as well as epilepsy. Seizure means it's a transient altered behavior which could be due to disordered, synchronous and rhythmic firing of a population of brain neuron. It's usually associated with the movement of muscle groups, which may be stiffening of the muscles, or it could be associated with this jerking movement of the muscle groups. And epilepsy means a chronic disorder of brain function. It's characterized by periodic as well as unpredicted occurrence of seizures. That means seizures are repeating. There are different causes for this epilepsy, and most of the time it's idiopathic in nature, and certain genetic causes or injury related causes can also be associated with this onset of seizures. And certain drugs like sevoflurane or tricyclic antidepressants, they all can lead to the development of these seizures. According to literature, there are more than 40 distinct forms of epilepsies. This is only a basic classification for this seizure, and it's purely based on the site of onset for the discharge for the starting of the seizures, which could be focal onset seizures as well as generalized onset seizures. Under focal onset, seizures, it includes focal aware, focal impaired awareness, and focal to bilateral tonic-clonic seizures. And under generalized onset, which could be generalized tonic-clonic as well as generalized absence seizures, myoclonic seizures, atonic seizures, as well as epileptic spasms. And now comes to this anti-epileptic drug proper. On theoretical point of view, an ideal anti-epileptic drug should suppress all types of seizures, and this drug should be without having any untoward or side effects. So before moving into each agents, we shall see how these agents are acting and how these agents are classified based on their major mechanism of action. The first one is this modulation of voltage gated ion channels. The ion channels including sodium, potassium or calcium, and under this agent may prolong the inactivated state of sodium channels. That means they delays the recovery from a closed state. And there is positive modulation of potassium channels and also inhibition of calcium channels. And the second major mechanism is enhancement of GABA mediated synaptic inhibition. GABA is the inhibitory neurotransmitter in the CNS. So by enhancing this GABA mediated transmission, this agent can depress the seizure activity. Under this, there is this agent act by acting on the GABA A receptor, modulating the GABA metabolism as well as inhibiting the GABA reuptake. Now the third major mechanism of action is by modulating the synaptic release of neurotransmitter. So different neurotransmitters are stored in a synaptic vesicle in presynaptic membrane. So for the release of this neurotransmitter, there should be some changes which should be taking place in the synaptic vesicle. So if you modulate or changes the structural integrity of this certain glycoproteins which are contained in the synaptic vesicular membrane, we can alter the release of this neurotransmitter. So it's they modulate the synaptic release by acting either on the synaptic vesicular glycoprotein as well as they have certain calcium channel containing alpha 2 receptors in the presynaptic membrane. And the fourth mechanism is diminishing the synaptic excitation, which is mediated by the ionotropic glutamate receptors like AMPA receptor. Now this is only a type of classification for these anti-epileptic agents based on their mechanism of action. As we can see, one drug may have more than one type of action. So these agents have one primary mechanism of action and other secondary mechanism of action. So we will discuss about their primary mechanism of action when we deal with each drug specifically. So now it's only a simple classification. The first one is prolongation of sodium channel inactivation. So this mechanism followed by phenytoin, carbamazepine, valproate, lamotrigine, topiramate, sonezamate, lacosamate. And the second is inhibition of the excitatory glutaminergic synapse, which includes phenytoin, valproate, barbiturate, lamotrigine, topiramate, levetiracetam, lacosamate. And the third mechanism is facilitation of the GABA mediated chloride channel opening, which is followed by benzodiazepines, barbiturate, valproate, vigabatrin, gabapentin, and tiagabin. And inhibition of the T-type calcium current, which is followed by this ethosuximide, valproate, as well as sonezamide. Coming to the conventional antiepileptics. Conventional means these are the agents which were discovered initially, and they were using for the management of the epilepsies initially. Still now, most of these drugs they are using in different situations, but now they have certain additional fronts like newer agents. So first we will discuss about these agents, and later we shall move into the newer additions. So the conventional anti-epileptics includes Phenobarbitone, Primidone, Phenytoin, Phenytoin, Ethosuximide, Carbamazepine, Oxcarbazepine, Valproate, Divalproex, Clonazepam, Diazepam, Lorazepam, and Clobazam. Now we shall move on to those anti-epileptic drugs. Their primary mechanism of action is to prolong the sodium channel inactivation. That means in the activated or open state, these channels conduct the sodium ion. So action potential is transmitted across the synapse. And in the inactivated state, there is no sodium channel conduction. So there is no conduction of action potential. So we can prevent this generation of the impulses across the synapse or across the neurons by using these drugs. They prolongs the inactivated state of voltage sensitive neuronal sodium channel. That means they slows the recovery rate or delays the recovery from a closed state, so which leads to limitation of the repetitive firing of the action potential. So we have our first agent is phenytoin or diphenylhydantoin. Initially synthesized as a barbiturate analog, and later it's found to have anti-seizure activity and widely used as an anti-epileptic drug now. It's a drug with a potent enzyme inducing capability. That means it induces microsomal enzymes like cytochrome P, P3F4 or P2C8 or 9, etc. So the important thing here is when you administer another drug which is also metabolized by these microsomal enzymes along with this phenytoin induces the metabolism of other drugs, and there will be therapeutic failure. So for example, if you administer oral contraceptive pills along with this phenytoin induces or increases the metabolism of these oral contraceptive pills. So we don't get the adequate concentration of these drugs in the blood, and there will be therapeutic failure of these oral contraceptive pills. And another important feature for this phenytoin is it follows a saturation kinetics. That means initially it follows first order kinetics, and when its concentration is increases, it's shifted into zero order kinetics. Coming to uses of this phenytoin, this agent is effective against all types of focal as well as generalized tonic-clonic seizures, and used in a dose of 100 mg twice daily, maximum up to 400 mg per day. And in status epilepticus, we should use this drug in a slow IV injection, but nowadays phenytoin is preferred over phenytoin. And the third indication is trigeminal neuralgia. Now it's only used as a second line agent, and first preferred agent is carbamazepine. Now we shall see the adverse effects of this phenytoin, and among this the first one is the adverse effect after prolonged use, which includes gingival hyperplasia, hirsutism, hypersensitivity reactions, megaloblastic anemia, osteomalacia, mild peripheral neuropathy, and as well as hyperglycemia is also there because it decreases the insulin release. So the use should be cautious in patients with altered glycemic status. And there's a peculiar teratogenic effect produced by this drug is known as fetal hydantoin syndrome. That means when you administer this drug in a pregnant lady, the born baby may have certain characteristics. So this syndrome altogether known as fetal hydantoin syndrome, and this is characterized by hypoplastic phalanges, cleft lip as well as cleft palate and microcephaly. Next is dose related toxicity. Among this is cerebellar and vestibular symptoms are the most dangerous one. Whenever you administer this phenytoin on a toxic dose in a patient, the first symptoms will appear is nystagmus, and followed by this ataxia, vertigo, diplopia, drowsiness, behavioral alterations, hallucinations, rigidity. All these features may seen, and it may be associated with this epigastric pain as well as nausea and vomiting. And the side effects following rapid IV injection is hypotension as well as cardiac arrhythmias. So whenever you want to use this drug through this IV route, you should use on a very slow nature, otherwise it suddenly precipitate cardiac arrhythmias or hypotension. Now few drug interactions of this phenytoin. So among this, the most important thing is the phenytoin is a potent microsomal enzyme inducer. So it increases the metabolism or increases the degradation of drugs like oral contraceptive pills, doxycycline as well as theophylline. So when you administer phenytoin along with this drug, their metabolism is getting increased, so which will lead to therapeutic failure of these agents. And another minute feature is that it has an ability to inhibit certain microsomal enzymes like cytochrome P2C 9 bar 19. So any drug which is metabolized by this enzyme whose metabolism is getting stopped. So for example, is warfarin is metabolized by this enzyme. So when you administer warfarin along with this phenytoin, phenytoin inhibits the metabolism of this warfarin, and warfarin getting accumulated, and which leads to internal bleeding. And another drug interaction, sucralfate, which is used in peptic ulcer, which binds with the phenytoin and decreases the absorption, so leads to therapeutic failure. So our next agent is fosphenytoin. It's a water soluble prodrug of phenytoin. This drug is getting converted into phenytoin by the phosphatase enzyme in liver as well as in RBCs. The major indication for this phenytoin is status epilepticus through the IV route. Why this agent is preferred over the phenytoin for the IV administration? Because of its lower incidence of side effects. For example, very low incidence of purple glove syndrome, and this agent can be administered in a very faster rate as compared to phenytoin because of its absence of side effect. And purple glove syndrome means it's a local reaction. It's a very rare side effect following the IV administration of phenytoin. It's associated with painful red edematous extremities. And following this faster administration of phenytoin, there may be chances of arrhythmias or hypotension. Even though this fosphenytoin is also associated with these arrhythmias or cardiovascular collapse or coma, and these side effects are very less as compared to phenytoin. So our third agent is carbamazepine. This also follows the same mechanism of action of phenytoin. That means it prolongs the inactivated state of sodium channel. This carbamazepine is a potent microsomal enzyme inducer as compared to this phenytoin. It has another property that it's an auto-inducer. That means it induces its own metabolism. Now let's see the uses of this carbamazepine. It's a drug of choice for focal onset seizure as well as trigeminal and glossopharyngeal as well as other neuralgias. It can also be used for other seizures like generalized tonic-clonic seizures. It's an alternative to lithium in manic depressive illness as well as acute manias, and its another property is it enhances the anti-diuretic hormone action. So it has an anti-diuretic effect, and which is effective in the management of diabetes insipidus. The most common dose is 200 to 400 milligram thrice daily, and in children it's 15 to 30 milligram per kilogram per day. And then its adverse effects. The first one is dose related adverse effects, which includes sedation, vertigo, diplopia, ataxia and dizziness. And at toxic doses, this leads to vomiting, loose stools, convulsions, cardiovascular collapse as well as coma. And it produces certain hypersensitivity reactions also, photosensitivity reactions, aplastic anemia, rashes, mild leukopenia, etc. And this agent is also has the potent ability to produce teratogenicity, which includes neural tube defect and congenital malformations. Our next agent is Oxcarbazepine. It's an analog of Carbamazepine, which is rapidly converted into an active metabolite which takes its action. It's a less potent enzyme inducer on comparing with that of Carbamazepine. So there are less drug interactions as well as adverse effect. And its hepatotoxic risk is also less. But its hyponatremic effect is more because of its ADH-like action. The major use is focal onset seizure in adults as well as in children. Now we can move on to second group of conventional antiepileptic drug, which acts by enhancing the GABA receptor mediated synaptic inhibition. That means when a drug binds to a GABA receptor, there will be increased chloride conductance through the central pore. This increased chloride conductance leads to hyperpolarization of the postsynaptic membrane, and which leads to inhibition of the transmission of action potential. Under this, the first group of drug is barbiturates. Barbiturates could be GABA mimetic as well as GABA facilitatory, but the primary role is to GABA mimetic. That means when barbiturate binds to the GABA A receptor, it increases the duration of chloride channel opening. So by increasing the chloride channel opening duration, it increases the conduction of chloride ions. So increased conduction of chloride ions through this chloride channel leads to hyperpolarization of the postsynaptic membrane, and it leads to inhibition of the conduction of action potential. And it along with that, it also said to have anti-glutamate activity. Glutamate is the excitatory neurotransmitter. So by inhibiting this excitatory neurotransmitter, this barbiturate groups, it inhibits the exciting activity in the CNS. This GABA is the inhibitory neurotransmitter in CNS, and it also said to have certain inhibitory property in the calcium channels also. And at levels exceeding the therapeutic concentration, it limits the sustained firing of the repetitive action potential. So Phenobarbitone is the first agent in the barbiturate group. It is the first drug came into the use as an anti-epileptic drug. So this drug is a very good microsomal enzyme inducer, and it induces its own metabolism. So it's an auto-inducer drug. This agent has high anticonvulsant versus hypnotic activity ratio. This agent is effective in generalized tonic-clonic seizures, simple and complex partial seizures, and in status epilepticus. It's most commonly used in a dose of 60 mg once or up to thrice daily in an adult, and in children it's used in 3 to 5 mg per kilogram per day. And the side effects associated with its use include sedation, ataxia, nystagmus, impairment of learning as well as memory, and it may lead to hyperactivity in children as well as mental confusion in elderly people, and megaloblastic anemia, rashes, osteomalacia, and hypoprothrombinemia with hemorrhages in newborn as well as teratogenicity. So the second agent is Primidone. It produces certain active metabolites like Phenobarbitone as well as phenylethyl malenomide, and these active metabolites are actually responsible for its anti-seizure activities. On comparing to Phenobarbitone, it's less potent, but its anti-epileptic efficacy is comparable. It's mainly used as an adjuvant drug for generalized tonic-clonic seizures as well as focal seizures, along with Phenytoin or Carbamazepine, and it could be used as a first-line agent for essential tremor, along with beta blocker like propranolol. So the second group of drug which modulates the GABA activity is benzodiazepines. These agents are GABA facilitatory. That means they increases the frequency of chloride channel opening. While discussing about the barbiturates, we said they are GABA mimetic. That means they prolongs the duration of opening of chloride channel. But these benzodiazepines are GABA facilitatory. That means they increases the frequency of opening of chloride channels. And at high concentration, they decreases the sustained high frequency firing of neurons. So the conduction of action potential is impaired. And these agents are mainly preferred for acute management of epilepsy or seizure disorder, and they are not indicated for chronic therapy because of their prominent sedative effect, as well as on using for a longer period there will be development of tolerance to their certain actions. So now our first agent is Clonazepam. This is the benzodiazepine with prominent anti-epileptic activity. It's useful in absence seizures, infantile spasms, acute mania, and it's also useful as an adjuvant agent in myoclonic as well as akinetic epilepsy. And it produces certain adverse effects like sedation, behavioral changes, motor disturbances, ataxia, and sometimes it leads to increased salivation as well as increased respiratory secretions. So the next agent is clobazam. It's the benzodiazepine with less prominent sedation and psychomotor retardation, and the chances of development of tolerance to its action is also less prominent. It's useful in focal, secondary generalized tonic-clonic seizures, absence seizures, and atonic seizures, and also could be useful as an agent of choice for a seizure disorder syndrome known as Lennox-Gastaut syndrome. It produces the adverse effects like dysarthria, somnolence, behavioral changes, as well as drooling. And now it's Diazepam, which is a prototype drug among the benzodiazepine. It is the first line drug for emergency control of seizure as well as seizure like manifestations, which includes status epilepticus, tetanus, eclampsia, and any drug poisoning which manifests as convulsions. And we can use rectal Diazepam for emergency control of febrile seizures in children. It produces thrombophlebitis of the vein or fallen BP on IV administration, and in very rarely it produces respiratory depression. So our next agent is Lorazepam. On comparing to that of Diazepam, this agent has more sustained action and lesser local side effects like less thrombophlebitis. It's also used as an emergency drug for the rapid or acute management of seizures. It's a drug of choice in status epilepticus and for emergency control of seizure of any other etiology. And now we shall move on to the next group of conventional anti-epileptic drugs. And these agents act via inhibition of the T-type or transient type of calcium channels. By binding to the calcium channels, they inhibit the conduction of calcium across the calcium channels. So there will be inhibition of the action potential conduction. Under this category, Ethosuximide is our first agent. It inhibits transient or T-type calcium current in the thalamic neuron. This agent is a drug of choice in absence seizure, mainly in children, and also can be useful in myoclonic seizures as well. The major adverse effects associated with its use include gastrointestinal intolerance, mood changes, tiredness, drowsiness, inability to concentrate, and some hypersensitivity reactions too, which includes rashes, discoid lupus erythematosus, and blood dyscrasias. Coming to our next agent, it's Valproate. It's a broad spectrum anti-epileptic drug. This agent exhibits different mechanism of action, and the inhibition of T-type calcium channel is only one among this. It prolongs the inactivated state of sodium channels, and there is enhanced release of GABA either by inhibiting the GABA transaminase enzyme or by stimulating the glutamic acid decarboxylase enzyme. Coming to the uses of Valproate, it's a drug of choice for absence seizures in adults and also as a drug of choice in atonic seizures. It's a most effective drug for myoclonic seizures. It can be used as a first line agent for generalized tonic-clonic seizures, focal seizures, and it can be used as an alternative to lithium in mania as well as bipolar disorders, panic attacks, and also it could be used in migraine prophylaxis. The dose at which it's used is in adults it starts with 200 milligram thrice daily and maximum up to 600 milligram 3 times a day, and in children it's 15 to 30 milligram per kilogram per day. Valproate is a potent microsomal enzyme inhibitor. That means it inhibits the metabolism of co-administered drugs, and which leads to accumulation of the other drugs and their toxicity. It produces certain adverse effects like gastrointestinal upsets, ataxia, drowsiness, tremor, alopecia, weight gain, and increased bleeding tendency. And there are chances of hepatotoxicity in mainly in children, and pancreatitis, hypersensitivity reactions, teratogenicity, especially neural tube defect. Now we are moving on to the next session of our topic. It is newer antiepileptics. These newer agents are add-on drugs to the conventional antiepileptic drugs. They came into the use only after 1990s. They are equally effective, better tolerated, and are having fewer drug interaction with respect to the conventional or the existing one. Now let's see the classification of these newer antiepileptics. It's based on the mechanism of action. So the first group is those acting via the sodium channels, which includes lamotrigine, topiramate, zonisamide, lacosamide, and rufinamide. The second group is those acting via GABA receptors. That means gabapentin, vigabatrin, tiagabin, stiripendol, and ganoxolone. And the next group is those acting via the NMDA receptors. Example is felbamate. And those agents act via AMPA receptors includes perampanel. And our next group is those acting via synaptic vesicular protein SV2A action, which includes Levetiracetam and Brivaracetam. And the last group is those acting via the potassium channel, which includes retigabin. So our first group of drugs in the newer antiepileptic is those modulating the SV2A action. And what do you mean by this SV2A? SV2A is a synaptic vesicular protein. So I will discuss about these things. So first of all, you just see this is a synapse. So there is a presynaptic membrane, synapse, and a postsynaptic membrane. So in the presynaptic membrane, the neurotransmitters are stored in the synaptic vesicles, and when an impulse comes, that means impulse comes to the presynaptic neurons. So according to this impulse, these synaptic vesicles, which contains the neurotransmitter, they goes and binds to the presynaptic membrane, and the adhesion takes place between these synaptic vesicles and presynaptic membrane. So as a result of this adhesion and following events, this synaptic vesicles which contains a neurotransmitter, they are being released into the synapse, and these neurotransmitters goes and binds to the postsynaptic membrane receptors, and the impulses are conducted. This is the usual thing. So for the adhesion and release of these neurotransmitters from the synaptic vesicle into the synapse, there will be certain changes takes place in the wall of the synaptic vesicle. So these structural changes are mainly carried out by certain synaptic vesicular proteins, and SV2A is one among that synaptic vesicular proteins. And here we have certain drugs which goes and binds to this synaptic vesicular protein and modulates the release of certain neurotransmitters, for example glutamate or GABA, and here we are going to discuss about them. Levetiracetam is the first agent in this group. It's a broad spectrum antiepileptic drug. It binds to the synaptic vesicular protein SV2A and modulates the release of neurotransmitters like GABA as well as glutamate. It also affects the intracellular calcium release. Levetiracetam is rapidly and almost completely absorbed following oral administration. It does not bind to any plasma proteins. It has a T-half of around 6 to 8 hours, and there is no significant drug interaction for this drug, and it's only 30% of this drug is metabolized, and rest is excreted unchanged through the urine. Coming to the uses, as an adjuvant agent in partial onset seizures as well as in myoclonic epilepsy, and could be used as a second line adjuvant agent in generalized tonic-clonic seizures, absence seizures, and it produces certain adverse effects like headache, anorexia, behavioral problems, sleepiness, and it's not usually approved for use in children. And we have our second agent is Brivaracetam. This is an analog of Levetiracetam. It follows the same mechanism of action of Levetiracetam, and it also has the ability to inhibit neuronal voltage gated sodium channels. Its uses includes as an adjuvant agent in the treatment of refractory partial onset epilepsy, and as well as those adults with certain photosensitive epilepsy. And that's all about the first part of antiepileptic drug. We will discuss the remaining in the second part. Thank you.